Hi, this is Elliot Fishman, and welcome to our latest Facebook Live. I think I'm live. I'm watching my thing turn. And yes, we are live 3 seconds ago. So let me again say it in case it was cut off. Welcome. Today is Thursday, and I know that we do appreciate you showing up here. I think it's kind of funny how it does seem like the days merge, and I'm sorry. I apologize for being about 10 minutes late. I had a call that ran over. I've been on calls and different meetings and stuff this morning, patient related and other related things, and every call seems to run late. I think you have more and more people who are either home or in their office. No one's traveling, so the old days of making a meeting was often difficult, but now it's easy. I mean, you know where the people are. I mean, you're home or you're at work, but you're surely not in some foreign country or some foreign land or even at the mall. So everybody is available. So I'd like to welcome everybody. And hello to John Biacchino from Body CT across the street, where we're really busy. I think probably most of you, I know different parts of the country have different issues and different parts of the world have different issues with the pandemic. Some places are getting better. I was just speaking to people in Erlangen, and they were saying the main hospital there for the first time has no COVID patients at all. So they seem to be loosening things there, and things are holding steady. And then I read about things in California and Florida and Texas, particularly Texas, where things have gone from bad to worse. And so we hope all our friends there are doing okay, and that we get through that as well. So it is a challenge, and as we've said before, this challenge is not going away. This will be the ups and downs over the next minimum of the next year, and probably a year plus. So it is going to be a challenge for all of us. I think one of the things we do, and CTisus, is we are constantly producing content for you. A lot of it at the time related to COVID, and then we've now gone back to doing non-COVID things, since most of us are getting busier and busier. I think probably at Hopkins, I would say our volume's not where it was before, but it's probably in the 90+% range. So we're getting busier and busier, and you can feel it by the day. There's a lot of precautions, a lot of safety, things like that. So we really are, moving forward. So I think we're doing a lot of topics that are really good. Just several things to also mention is that Sarah and Lily have been working hard on updating all of our apps. Our newest, Apple's been giving us a little bit of a hard time on our icons. You can imagine the icons are the issues. The icons for iPad and iPhone look the same, and that's confusing, so you need to have different iPads. And so we're working on that, but there's a terrific new version of the iQuiz, which has 60 new cases, 6 months worth, with about 600 pearls. So I spent about a week writing those pearls and reading and writing, so it should be terrific. We have a new version of the iLectures, which is coming out momentarily, and we've updated all of the other apps to the newest Apple software. So there's a lot of changes, all very positive in that regard. So I hope you'll see some great things, and I am preparing new lectures. I'm working on a bunch of things, not so much saying, let me update CT of the pancreas or CT of the liver or CT of the kidney, but creating new talks. I just finished the talk that'll be, I think August 10th will be on CT of renal lymphoma, and I'm working on hepatoma this weekend and a few other very focused topics. So we are trying to build out and really emphasize things that people have suggested that we do. We also are updating the teaching files, our new protocols. I have a call tomorrow which is to finalize the last 3 protocols, and then total new set of protocols and updates will be available to you, and that'll hopefully be next week. I think I may have been the slow point in this, or one of the slow points in getting it done, but that should be there next week. I know we tried for July 1st, but that's pretty close. It's July. This talk, I thought I would talk about the liver. So, one of the things that we do in terms of CT, regardless of the patient's application for the CT, whether it's in fever or it's staging tumors or unexplained weight loss, is looking at the liver. And the liver, we talk about inflammatory disease and we talk about neoplastic disease. There's other things, congenital disease, colorectal cysts, biliary atresia, but I won't speak about that. I'm going to speak about masses in the liver. We know masses, if you use the term mass, it sounds bad, but the truth is most liver masses are cysts. That's the most common liver mass. And a lot of them are hemangiomas. 10% of people have hemangiomas. Over age 50, 20, 30% have liver cysts. So having something in your liver is not uncommon. Most of the time it's very easy. In fact, the biggest challenge we have sometimes is as scanners got better, we have these really tiny liver lesions, which are cysts or hamartomas or hemangiomas. And I'm always making the point that simply detecting more lesions is not good enough, because if you have a patient with a stage 1 colon cancer, suspected to be stage 1, and you say there's a liver lesion that can't rule out a met, then all of a sudden maybe the patient's stage 4. Do you have to biopsy it? Do you have to resect the liver? What is it you do? So it's not just saying there's a liver lesion, but knowing when to sound the alarm. And most of the time I can tell you benign versus malignant, but sometimes I can't. So maybe you need a biopsy, maybe MR will be helpful, maybe PET will be helpful. The presence or absence of liver disease, even a 1 centimeter lesion, is critical. It makes someone go from stage 1 to stage 4 potentially. A liver lesion in pancreatic cancer, your survival goes down, your rate of recurrence goes up, because once you have it in the liver, it means it's systemic. So we talk about those things as well and how we manage that. So let me tell you a little bit about how I think about the liver. So if you could do the liver, you would have multi-phase acquisition, maybe arterial and venous, maybe delayed thrown in there, non-contrast. We used to do a lot of non-contrast, particularly in cirrhotic patients. Mike Federley did a lot of articles about that. But even Mike, who is retired now, congratulations, Mike, when he was at Stanford, he stopped doing non-contrast. It wasn't worth the dose, and you really didn't get that much information. Most of the time we did cirrhotic patients, is when the non-contrast was thought to be helpful, because in that scenario, you would say a high-density lesion was probably a regenerating nodule than a hepatoma. So that may have been where it was helpful, in that regenerating nodule versus hepatoma in patients with long-standing liver disease, Hep B, Hep C, for example, as 2 good examples. Ideally now, we do 2 phases in the liver. I find arterial phase in about 30 seconds, and venous coming back at about 70 seconds is ideal. We can look at staging tumors as well as defining what tumors are. People ask, what about delayed scans, 4 or 5 minutes? Every once in a while, a delayed scan is helpful if you're not certain the lesion's filling in correctly. If you're thinking about, will a lesion enhance on delayed, maybe it's a cholangiocarcinoma, it can be helpful getting a delayed scan. But in general, we're doing 2 phases. We're doing dedicated liver. I think it's a challenge with 1 phase at times, particularly if you have only arterial phase. Venous lesions may not show up. If you only had 1 phase, probably in the scheme of things, the venous might be better, in the sense that a lot of the venous lesions on the malignant side are things like colon cancer, lung cancer. They're going to show better. We also know that the tumor, if you're looking at lesion detection in terms of malignancy, the tumor type will define when the best acquisition is. So for example, if you have a neuroendocrine tumor of the pancreas or a carcinoid neuroendocrine tumor of the small bowel, if you don't do arterial phase imaging, you're going to miss the lesions. So again, where you're coming from in terms of your requisition will be very important. So if we're doing a routine colon cancer and it's just following up liver as part of a follow-up study, venous phase is going to work out very well. But if you tell me I'm doing a carcinoid tumor, I better have the arterial. And with carcinoid, arterial and venous work well, because you can really judge the lesions and not confuse a hemangioma with a vascular malignancy. So again, understanding that is very critical. We'd like to give about 100 to 110 cc's of contrast, injecting 4 to 5 cc's a second, starting scanning at about 30 seconds for arterial and about 70 seconds or so for venous. That's on a 64 slicer or better scanner. We also like to do post-processing. If you look at some of the lectures I have on CTisus, you'll see a lot about post-processing about the liver, because things we look at are the vessels. When we talk about things like FNH, the enhancement is a vessel that goes to the center of the lesion, the central scar. When we talk about hemangioma, there's vessels that go to the periphery, and you have the puddling. So that becomes very, very classic. When you have the enhancement pattern, 60 seconds out, hemangioma, peripheral puddling, and then you get central filling it over time, as opposed to FNH, where the lesion is homogeneous and there's a central scar with the vessel to the central scar, versus hepatic adenoma, which may show enhancement, but somewhere between FNH and hepatoma. We also speak, for example, about the fact that hepatic adenomas are typically considered pre-malignant. People are doing a lot of work now separating based on the pathology, the type of hepatic adenoma you're dealing with, and which ones have a higher suspicion of malignancy, and which ones are more likely to be non-malignant. And so, people decide based on that whether or not you should resect a hepatic adenoma. Most people will resect hepatic adenomas if they're resectable because they're worried about them being pre-malignant. So we're learning a lot more about the genotype of these lesions. And so we're learning a lot, and maybe we'll speak about that a different day. I've been doing some work on that myself in terms of putting together a talk on CTisus on that topic. So you may find that very helpful again. Let's see what else we can talk about. So in terms of the liver, so when I look at the liver lesions, I'm looking at arterial to venous, and I'm looking how things change. So most common liver lesion is a cyst, right? Cysts, water density. If they're large enough, they can cause perfusion changes, they can displace vessels, but there's no neovascularity, there's no wall enhancement, there's no feeding vessels. If you go, now vessels you might sometimes are stretched, but if a cyst is large enough, it can be stretching vessels, just like if a cyst is large enough, it can cause symptoms because it creates mass effect. Now, if you go from there to hemangiomas, in the old days we would say peripheral puddling and then peripheral to central filling in, and the lesion would have to fill in its entirety. I remember way back when there were a million techniques for evaluating hemangiomas. I also remember that it was felt that unless a hemangioma filled in its entirety, it couldn't be called a hemangioma. Now we know that hemangiomas commonly have central scars, which I initially described in FNH, but you can see central scars in cholangiocarcinomas, hepatomas, hepatic adenomas, FNH. FNH is usually a vessel feeding into the central scar, and that central scar, which is fibrous tissue, will become isodense on later phase imaging. And other thing about FNH, the lesion's vascular, fairly homogeneous, but it's only as bright as the IVC. It's not as bright as the aorta, so that's a very helpful thing. If we go from hemangiomas to FNH, again, FNH, that homogeneous enhancement, central scar filling in, I don't think you're going to confuse FNH with hemangioma. Hemangioma never is homogeneous early. FNH always is. I think we have more of a challenge with hepatic adenomas. To me, hepatic adenomas don't have those criteria of homogeneous enhancement. They're irregular. They have all sorts of issues in terms of their vascularity, can be very vascular, can be irregular. I think the biggest challenge with hepatic adenomas is not just looking and saying hepatoma next case. Hepatomas, we talk about the fact that 80% are in cirrhotic livers. So if you see a normal liver, you don't really think about hepatoma, though it can be. And in younger patients, can have hepatoblastomas, for example. And those are really young, under 10. And teenagers, 20s, 30s, can have fibrolamellar hepatomas, which are very vascular, often with a central scar, often with calcification. Fibrolamellar hepatomas typically do better than classic hepatomas. The classic hepatomas, I mentioned, are in cirrhotic livers. So if I see a cirrhotic liver, two things I know. One, if something's vascular, it's not a hemangioma. You never see hemangiomas within cirrhotic livers. Now, what happens, of course, is hemangiomas are sacs of blood, right? With cirrhosis, you get fibrosis and things collapse. And so hemangiomas are gone. If I see a vascular lesion, even if it's 1 centimeter in a liver that's cirrhotic, I'm saying hepatoma till proven otherwise, okay? Hepatoma till proven otherwise. That becomes very, very important. Hepatomas can be small, they can be large. I'll be speaking about them this week. Neovascularity, the bigger ones particularly have a pseudocapsule. It looks like you almost could divot them out, but you can't. We talk about the neovascularity, the irregular vascularity in hepatomas. We talk about the presence of adenopathy. We talk about hepatic adenoma. We talk about hepatomas versus cholangiocarcinomas. Cholangios are typically not as vascular. Cholangios are typically more central. and cholangios commonly dilated the intrahepatic ducts. It's interesting that hepatoma, even when they're large, it's rare for them to cause duct dilatation. Again, the cirrhotic thing makes my life a little bit easier, but you do see hepatomas in non-cirrhotic livers. There's a number of risk factors for hepatoma, certain diet, certain travel, certain age. But again, cirrhosis is the thing that really makes me think about it the most. We then talk about metastasis. Well, Mets can be almost anything in terms of appearance. Mets can be solitary, can be multiple, can be vascular or hypovascular. Mets typically depend, and Mets are more common than primary tumors, of course. Mets depend on the primary tumor that they come from. So if you have a colon cancer met to the liver, it's hypodense. If you have a met from a neuroendocrine tumor, if you have a met from renal cell carcinoma, particularly clear cell, they're typically very, very vascular lesions, and their mets, not surprisingly, are very vascular. So you'll see very vascular liver lesions. If they're large enough, it's impossible to distinguish a met from primary hepatoma because both can be very vascular. So I do think about things in that way also. Obviously, if a patient presents weight loss and you see a big liver mass and it's vascular, I think hepatoma first, but then I look carefully to make sure there's not a different tumor present. If you have liver lesions that are cystic and the thickened wall, you know they're malignant, right? It's not an abscess. Sometimes it can overlap. I've showed you some cases like that. It's not a simple cyst. Cystic mets, think of ovarian cancer, think of GIST tumors. So you want to think about even melanoma occasionally. So you want to think about those and look for those primary tumors. If the patient has no diagnosis, see a pelvic mass and a liver mass and it's cystic, it's ovarian cancer. So there's things really to think about. We do put a lot of effort into post-processing, and I'm going to speak about cinematic rendering next week. Post-processing is very good for defining the vascular supply of the tumor, which can be helpful with embolization of surgery or planning surgery and determining if surgery is possible. We talk about vascular mapping as a way of helping me determine what's an FNH and what's hepatic adenoma. We talk about the vascularity of hepatocellular carcinoma and the hypovascularity of a metastatic renal cell carcinoma. So let me look, we're about 17 minutes in, so I want to watch people's time, but so let's see. Rita's from Georgia. Now I guess I would have to admit they have a few cases of COVID, 5 cases a day. I assume that's Georgia, like the state of Georgia, and not Georgia in Russia. We have a lot of fans from there. I see Philip Taylor calling us in or checking in from Northern Virginia. And Virginia has a moderate amount of cases, not that bad. I see people logging in from Libya. So I haven't read too much about Libya. Hopefully things are relatively quiet there. I guess in the Middle East and Africa, the numbers are up a little bit, but they're pretty stable. They've not been hit as bad, and I don't know if it's related to genetic reasons or it's related to the warmer climates. It's really hard to tell. But I also think a lot of places in the Middle East are being extremely careful. A lot of the Middle Eastern countries, whether they're putting people in quarantine or they're just stopping people at the border or not letting flights come in at all, I think they've been very, very aggressive. And then we have people from Jamie is saying from Glen Burnie, that's about 10 miles away or less from Hopkins, and Lydiana, who's in Palo Alto today. I saw Lydiana at the beach the last couple of days, of course, social distancing with her dog. And then Andrew from Los Angeles and Mashi from the Maldives. So it's quite a difference between Los Angeles and the Maldives. But we do appreciate everyone who does visit us. If anyone has any questions, this would probably be the best time to ask them. Again, people often ask me questions after this talk is over. You know that this talk is posted back on Facebook. It's also posted on YouTube, and it's also posted on Instagram. So you can see it back. Next week I'm speaking about cinematic rendering, and we're gonna, Facebook has changed the interface for Facebook Live, so we're gonna try to work it that I can show images. I'm gonna try to give a talk on cinematic rendering and try to tell you why you should be doing cinematic rendering and some of its advantages. So that becomes, that'll be next week's topic. And then the last thing, hello Nancy. Nancy's from Egypt. So we do corner the world, or a lot of the world, and we do appreciate everyone coming. So that, again, hopefully it'll help you a little bit thinking about liver lesions. Again, the key thing to think about is not just picking up a liver lesion and saying the patient has a mass, but being very specific as to what the mass is. You're not always going to be perfect, but you want to be able to say this is benign, this is malignant, this needs a biopsy, this needs follow-up, this needs an MR, something else. And the treatment, and of course, not to create havoc where all of a sudden you're reading everything as malignant when it's a bunch of benign lesions. So with that, we're at the 20-minute mark. I'll stop there. I'll thank everybody for their attention, and hopefully we'll see you next week. And thanks for coming.